Okay, so I'm going to talk about physiological cysts and using IOTA benign descriptors as simple ways of classifying ovarian masses. So just first of all, this slide is one of my favorite slides. Just tells you everything you need to know about classifying ovarian masses. Here we go. You've got Blueberry Muffin, you've got a Chihuahua. Now, all of you hopefully can tell the difference between the two, but actually, if you look, they've got very similar features. But because you're human beings and you know what dogs look like, and you've been exposed to these all your life, you've got no problem discriminating between the two. But if you've got artificial intelligence to try and do this, then it might potentially be a bit of a struggle. So if you don't take care, you could end up eating someone's dog. You don't, because you're so good at this type of image analysis. And that's basically what we do when we look at ultrasound scans as well. So if you look at the range of masses that you're going to see, you have ones, if you can see here on the left, which are easy, and then they're getting more difficult as we go over to the right. So these are physiological cysts, which we're going to just quickly mention. You can see these are hemorrhagic cysts with retracting clot, typical hemorrhagic cysts. These will generally resolve over 6 to 8 weeks, which we'll talk about briefly. And then you've got relatively straightforward cysts, which we can sort out with benign descriptors. And you can apply these benign descriptors usually in about 35% of cases, but it could be up to 70% of cases, depending on the population that you're studying. So if you're studying a low-risk population. And then the question then is, what do you do if you can't apply the benign descriptors? And for those, I would argue you can use adnex, which Dirk Timmerman's going to talk about in a minute, or you might use subjective impression by an expert. And so a very plausible approach would be that physiological cysts can be rescanned at an interval and will resolve. Other cysts you will sort out with benign descriptors, and then you'll have a two-step strategy using benign descriptors and then adnex. Dirk will discuss this later. Or you can use adnex for all of them, but I would argue that's not necessary. So let's just think about the different types of pathology that we don't apply models to. Here we have classic hemorrhagic cysts. These are physiological. They're going to resolve in 6 to 8 weeks. You often, occasionally people think these are solid areas, but you can use Doppler to sort that out. And you can also use the advantage you have of vaginal ultrasound. If you prod these cysts, the jelly inside them will wobble. And you can see that, for example, here, where you're just gently pushing on the cyst, and you can see the cyst contents are acting very much like jelly. And that's just a very simple way of knowing that you're dealing with a hemorrhagic cyst. But interestingly, all over the world, people operate on these. It's unusual to have to do so unless someone's in really acute pain. And we do nothing about hemorrhagic cysts, even if they're up to 10 centimeters or so, because we know just even if they're quite big, they're going to go away without the need for intervention. You can also have follicular cysts, of course, which have no hemorrhage, and the same applies to that. Sometimes, however, these cysts will rupture and cause problems, particularly, for example, as this woman did, she's on anticoagulants, and you can see the simple physiological cyst rupture. She's got quite a lot of blood here. She's got blood above the fundus of the uterus. She's also got blood in Morrison's pouch. And on laparoscopy, you can see she's certainly got quite a lot of blood presence. And here we have where she was bleeding from. It's as simple as that. So on occasion, even with a physiological cyst, you will end up actually having to take action. But generally speaking, this is not the case. Another example of a cyst you should be aware of, which can cause pain. This is, sorry, a mass or a condition that you should be aware of. Here we have ovarian torsion, typical peripheral follicles, somewhat blurring of normal ovarian architecture, ovarian edema, and this is a classic picture of ovarian torsion. Often you can use an abdominal probe because the ovary is displaced out of the pelvis. But this is just something to be aware of. And of course, to be aware of the fact that you untwist these, you detort the ovary in these circumstances, and almost all of the time, these ovaries will reperfuse. And just to emphasize the fact you do not need to remove the ovary. Untwist them, usually the ovary will be okay. And if there's a cyst on the ovary, which isn't always the case, then remove that cyst at an interval. Pelvic abscess, you can see, can look quite complex, typical ground glass appearance, often with an incomplete septum, as you can see here, generally bit more vascular. And of course, you have to look at the clinical position of the patient. They're going to be tender. They may have raised inflammatory markers and so on. So you don't just treat a scan, you treat the patient. And I mentioned an abscess simply to encourage you to consider cyst aspiration. Seth Granberg and Knut Galen published this some time ago, but you can see under ultrasound guidance, relatively straightforward sometimes to put the needle in and aspirate the contents of an abscess, and so avoid laparoscopic drainage, which can be difficult. And if you look at their data, actually it's very good, almost over 300 abscesses, mean size between 3 and 15 centimeters, and they pretty well had success, most with just one aspiration, and by far the majority with two. And if you look, very few of these needed significant anesthesia, mostly done with some sort of sedation. So this is a good approach to dealing with abscesses. And of course, once you've got rid of the pus, then in general, the patient's symptoms, temperature, and so forth settle much more quickly. Okay, so what about benign descriptors? Well, benign, simple or easy descriptors, which are from the IOTA group, are really designed to classify simple cysts, dermoids, and endometriomas, as you can see here, because they have straightforward, very typical features. Now, we're not saying that all dermoids have these features, but when they have these typical features, they will almost always be a dermoid. And you don't need to use models or tumor markers or anything in these circumstances. And it's just an intuitive diagnosis that reflects clinical practice. So the question is, how many masses can they be applied to? Well, what are they and how do they perform? Well, there are four, and you can see here, first of all, unilocular tumor, ground glass, contents less than 10 centimeters. In a premenopausal woman, you can see typically for an endometrioma, unilocular with mixed echogenicity, acoustic shadows, you can see coming out here, less than 10 centimeters, again in a premenopausal woman. Pretty obviously, that's looking at dermoids. Then you've got anechoic unilocular tumors less than 10 centimeters, and then you've got the rest of them basically remaining unilocular tumors with regular walls less than 10 centimeters, which you might see, for example, with a mucinous cyst. What about test performance? Well, here we have IOTA phases 1 and 2, so 3,500 masses. Benign descriptors applied or could be applied in 30%. This is a quite high-risk group of patients where the prevalence of malignancy is 28%. But if you just look at how well they perform, correct outcome 99, 100, 99, almost 100% of the time, you're going to get it right that this mass is benign. And you're going to get the histology right most of the time as well. And there's now a lot of data now showing that benign descriptors work extremely well, and you can be very confident using them. Here we have this paper from Chiara Landolfo, which I think Dirk will talk about the whole picture. But you can see in this group of patients taken from IOTA 5, there were 4,900 masses, and the benign descriptors applied in 1,798, so that's 37% of masses. And you just have to look where the different descriptors applied. So that's descriptor 1, if you remember, endometriomas, 99.6% of the time, they would be benign. And again, with all the other benign descriptors, you can see exactly the same as with the previous data that I showed you. And very, very, very few, as you can see here, cases of, missed cancers. So I think you can be very confident. It's interesting to look in populations where if you like, lower risk populations. These are both papers that are currently under consideration. This is from Pascal's group, part of the IOTA group, looking at a group of patients who are being screened for ovarian pathology on an annual basis, so low prevalence of malignancy. And you can see that the benign descriptors could be applied in almost 80% of cases. And amongst all of these, only 2 tumors turned out to be malignant. So extremely effective, even in this very low-risk population. And this is Jen Barcroft's data on cysts in pregnancy. Benign descriptors could be applied in 70% of cases, and only 1 was misclassified as a borderline cyst. So again, you'll be able to apply the descriptors, it's more likely you can apply them when you've got a low-risk population in your referral clinic or in an oncology center, then obviously more complex masses and the number of cases where benign descriptors apply will be reduced. But in general, you can say between 30 and 40%. Extremely effective. So just one case, this stage is 27. You can see it's unilocular, mixed content, acoustic shadows. Which benign descriptor applies? Which one is it? Well, you can see it's this one. Unilocular tumour, mixed eccentricities, less than 10 centimetres. This is a dermoid cyst. And this one, fairly obviously, you can see this is going to be a straightforward endometrioma, classic history. And again, if we look, which one? And you can see this is going to be here, unilocular tumour, and it was, of course, a benign endometrioma. So very straightforward, but it's good to have this data to back up what you're saying. So if you just go back to that slide at the start, you can see now how you have physiological cysts. These will generally resolve and will not need intervention, even if they're quite large. It's not necessary to operate and will disappear. You've got these relatively straightforward masses that majority of these you can sort out, obviously not this one here, you'll sort out with benign descriptors, and it will vary the number of patients you'll be able to apply the descriptors to depending on the nature of the population. And then it's likely with the rest, as we're going to hear in a moment from Dirk, that you're going to be able to use IOTA adnex. So that's basically an introduction to an approach to deal with ovarian masses. And adnex can be applied to all, but I don't think that's necessary. So thank you. If you want to know more about this, I would refer you to the IOTA group website, as you can see, website, and also the Facebook page, as you can see here. And if you want to go to the IOTA website, you can use this QR code. If you want to contact me, you can find me here. So thanks very much. And obviously we can have a few questions, but we're now going to also have a talk from Dirk Timmerman. We're going to have an MDT later as well. So I think it's probably a good idea to sort of move on with these and deal with all the questions around the MDT, because I'm sure there'll be some coming in, but I will try and answer them as they come in. Okay, so I'm going to physiological cis and using IOTA.